Doctor, thank you so much. This is an important conference for us here in the country and in Atlanta. I want to start off with kind of a broad question. How far have we come?
Well, we have come enormously far, and I think I can say that with some degree of reflection, because I was involved with taking care of patients who had a disease that wasn't even called AIDS yet back in the fall and winter of 1981-82 when I first started seeing AIDS patients. And it was at a time when we had a disease, like I said, that didn't even have a name. It was called GRID by some, gay-related immunodeficiency. We didn't have an etiologic agent, and we absolutely didn't have any therapy. And then if you look at what's happened since then with the first drug that was used, AZT, in 1987, and then combinations of two drugs until 1996, and then from 1996 on with the triple combinations of drugs, so that today you have a situation, and I have a picture when I talk to people of myself in a room with a patient in 1982, literally having nothing to be able to give to the patient except comfort and care. And the median survival was about 12 months because they presented with advanced disease. Fast forward to today, with a single pill of 3 drugs in a pill, you can have someone who comes in with a maybe recent infection at age 25, and you can predict to them accurately, without hyperbole, that they could live an additional 50 plus years, which makes it almost a normal, not quite, but almost a normal lifespan. That's great news, but what's even more important with regard to what we're trying to do today is that we've now shown unequivocally, there was some doubt about it, but it's without a doubt now, that if you treat an individual, get their viral load to below detectable level, you make it impossible for that person to transmit the virus as long as the virus is below detectable level. So that is what we're referring to as treatment as prevention. You then superimpose upon that pre-exposure prophylaxis.
PrEP.
PrEP, which individuals who are at risk for HIV infection, if they take a single pill of Truvada a day, you decrease by about 95 to 97% the likelihood that they will acquire HIV infection. So where we are now, if you look at those two things, treatment as prevention and PrEP, theoretically, if you aggressively implemented both of those things, got everyone or most people who are HIV infected on therapy with a viral load that's undetectable, get all the people who are at risk to practice good prevention, including PrEP, and PrEP is very important. Theoretically, you could essentially end the epidemic. And that's what we're really talking about, that all of a sudden right now we have the tools to end it. So when you ask me how far we have come leaps and bounds from where we were.
But what do you say to the doctors? I didn't know about U equals U until 12 months ago when I publicly disclosed my status. And I was living with HIV for 10 and a half years at that point. I'd never heard U equals U. So what do you say to those doctors and those caregivers out there who say, well, U equals U, but it's not my opinion?
We don't go on opinion, we go on facts. And we did the study at the NIH when we first did the 052 trial. And that was the trial that showed that if you treated a person who was in a discordant relationship, one infected and one not, and you decreased the viral load, that you could actually have that person dramatically by 95% not transmit. But we didn't link it to viral load. 5 years later, we published another study in which we followed up on the original treatment as prevention study, and now we linked it to viral load, and we found out that there were no linked transmissions among the people who actually went below detectable level. There were obviously transmission with people who went out of the relationship. So there was a lot of doubt. They would say, well, you know, there were some heterosexuals in that. Does it really work with men who have sex with men? So we did a series of study with tens of thousands of people in this situation of determining if your viral load is below detectable level, do you transmit it to your uninfected partner? And the answer was there was no linked transmission. So when someone says, well, you know, people say U equals U, but my opinion is that it doesn't work. Well, then your opinion is not aligned with the facts, because we now have tens of thousands of people in cohorts that show that U equals U is correct.
How does U equals U? How does undetectable equals untransmittable change the game?
Well, it changed the game in so many different ways. It changes it from the standpoint of the actuality of not transmitting infection. It also changes it in two elements of stigma. the stigma that society looks upon an HIV-infected individual, that even though they look healthy and they feel healthy, there's always that deep-seated feeling that there's something dangerous about them.
Oh, don't I know, doctor?
Don't you know that they could transmit it? But probably as important is it the own self-imposed stigma that someone feels that because they have a virus that is still transmissible, that they feel somehow insecure. They feel that maybe they're not being a good citizen because they may be able to transmit it. But when you show scientifically that you actually equals you remove the stigma, but also the reality is that you don't infect anybody else.
What do you want people to know about HIV?
I want people to know, first of all, that HIV is a disease. If you have it, it's treatable. Don't feel because it's treatable that you should go out and be reckless about getting it, but it is eminently preventable. But then that's at the individual basis. The other thing I want people to appreciate, and that's what we're trying to do, and we're going to be discussing this time and again, is that we have the tools today to end the epidemic. I really feel strongly that it's an ethical and moral responsibility to implement those tools, because back when we had nothing, you were just scrambling to essentially caring for people, making them suffer less. Now that we have the tools, it would be unconscionable for us not to implement them.
What do you say to people who say, well, HIV, it's the gay man's thing. It doesn't affect me. I'm a happily married man with 3 kids living in the suburbs. This doesn't touch me, HIV. Well,
it does touch you. I mean, forgetting about the idea that it's very unlikely you're going to get infected if you're a happily married person. You're monogamous with your partner, but you're part of society. And there are 1.1 or 1.2 million people in the United States living with HIV. So HIV-infected people are an important part of our society. They also are an important part of the world. There are 36, 37 million people living with HIV. It's a disease that's ravishing people in certain countries. So we really should feel that it's our responsibility to be aware of it and to support the efforts to eliminate it.
Why should HIV-negative people care about undetectable equals untransmittable, you equals you?
Well, it depends. When you say HIV-negative people, there's a broad swath of HIV-negative people. If I'm an HIV-negative person and there is a chance that I will be involved in a situation where I could put myself at risk of getting infected, it is, I think, comforting to know that all the HIV people who are out there are not dangerous people. If they're treated and they're below detectable level, they're not going to give anybody any problems.
How do we change people's minds then? How do we put this into the mainstream? But I've said this before, you see campaigns and even the great work that the CDC does. And we have a poster of a white man holding his black boyfriend's hand, and there's an Asian doctor with a stethoscope around her neck and a transgendered nurse in scrubs, and we're all smiling, and it says undetectable equals untransmittable. From my experience, the mainstream don't give a, pardon my language, shit about that.
Yeah.
How do we get this out? I mean, it seems it's such a simple message.
Right.
But we know that it's not hitting as hard, especially in the United States.
Right.
I think internationally we're doing better. How do we get this out there, Doctor?
We just got to keep hammering at it. We have. I mean, there was a reluctance to be very proactive about it a few years ago. About a year and a half or 2 ago, I got up at the conference, at a major conference, and put a big slide up that you equals you. And I didn't do that lightly. I did it because I analyzed the data. And I'm a scientist, I'm a clinician. I've taken care of thousands of HIV-infected individuals. So I know what it means for someone to feel that they are untransmittable. So as soon as the data validated what I was saying, I felt very comfortable in saying it. And then as soon as I said it, then the others said it. Then the other one said it. And then all of a sudden it became kind of a self-propagating message. That doesn't mean that we can stop talking about it. And I think the plan to end HIV in the United States, the plan that was announced at the State of the Union address that we at HHS put together over the last several months, that we wrote about in that article where I described it all in the Journal of the American Medical Association. That situation is such right now that the basis and the foundation of that plan is you equals you plus PrEP.
And we should say U equals you. You said this. U equals you only if you were really you.
Well, that's right.
I remember that stuck with me.
No, I say that because it's true. Because if a person truly is undetectable, the one thing you don't want to happen is that someone will be careless and all of a sudden, without getting tested, saying, well, I'm going to go do whatever I want.
Right.
And your viral load is, 10,000 and you don't know it. You have got to make sure that intermittently you get tested to the point where you remain undetectable. And what we're starting to find out, that right now with the really good drugs we have, with the combinations of drugs, if you are truly undetectable, there may be a little blip that's irrelevant there, but you tend to stay undetectable. I mean, I'm following patients now for years, and we just keep bringing them in. We probably draw more bloods in them because it's a research organization. But we see that these people who take their medicines really do stay.
I've come up against people going, well, that's all good and well. Yeah, U equals you. Yeah, you have access to medicine. I don't have access to medicine. I can't. What about those of us who can't get the treatment? How do we affect the change? How do we make sure they get their hands on that treatment? And what don't people know?
Well, that's a commitment of society, and that's a healthcare issue that's much more difficult to universally get victory on that, because people of different socioeconomic status, people who don't have access, people who live in places, people who are poor, people who don't have insurance, people who don't get the care because of stigma, those are all different. It's not a unidimensional situation for people who are not on therapy. That's our societal responsibility to get people in care. Everybody has a right to be able to be healthy.
Right.
And whether you're poor, whether you live in a backward area of a rural state, or whether you're in the middle of a big city.
So what's the final message, Dr. Fauci?
Well, the final message is, again, that I believe as a nation and as a global community, we need to implement what we now have taken 37 and a half years to get, is the tools to really end this as an epidemic, but also protect people who are uninfected by U equals U or PrEP, and keeping people who are infected very healthy.
Well, thank you, sir.
My pleasure.
Appreciate it.
Good to be with you.